afternoon, everybody. I do feel privileged to be here in what I would consider a landmark symposium in implant dentistry. And I can't thank Salah Weiss enough for making me part of this symposium. When I was approached by Salah to present today, he asked me to think of all the things that I do in implant dentistry and show some clinical cases that would give a take-home message. So I went back to my cases and I decided, let's see what I worked and struggled with, and thought I wish I had something different that would make my results better. The title I was given was Bone Preservation Might Be the Answer. So the question here, to preserve or not to preserve the bone? And I really appreciate Salah's comments in the pre-symposium courses when he said, we're doing all this effort to build bone, and then we're going in with a drill and cutting it away. So let's look at a few cases, and based on those cases, I'm going to tell you my experience with the Osseodensification system. This patient was referred to me by a prosthodontist, Dr. Jonathan Esquivel from LSU School of Dentistry, faculty practice. And the patient had some problems, mainly a lot of decay and non-restorable dentition, and an arch that was not amenable to long-term results. This is the maxilla and the mandible, as you can see them. And you can see some teeth have decay, some teeth are not good support for full arch fixed restorations. And he has quite a severely resorbed ridge. When we do our planning, typically in New Orleans, we try to minimize the cost for the patient. New Orleans is not one of those richer cities where we have a lot of patients that can afford anything or disposable income, such as some patients that live in Florida. So we try to do something that is long-term, and it is dependable, and it's predictable, without costing the patient a fortune. So this patient wanted a fixed mandibular prosthesis, and he was okay with a maxillary denture. And this would save him some money. So the treatment plan by Dr. Esquivel was for us to extract the teeth. He'll make a denture, and we're going to convert the denture on the lower arch for immediate implant restoration. If we take a look at the ridge, when you're doing a hybrid type prosthesis, you need at least 15 to 18 millimeters of inter-arch space for all the hardware that's going to go on top of it. So when I took a look at the ridge, I realized the space is limited, and Dr. Esquivel was asking me to reduce at least 2 or 3 more millimeters from the ridge height, which worked fine because the top of the ridge was quite thin to begin with. So we start with our surgical procedure, and typically we do the extractions as atraumatically as possible. And we use the piezo-surgical instruments in order to flatten the ridge because it gives us a much better healing response, a little bit slower, but works quite well. And you can see in the slides the area of the ridge that was tabled down with alveoloplasty versus the one that is about to be tabled down. We're continuing with alveoloplasty, and now we have a ridge that is ready to receive the implant osteotomy site preparations, and this was at a time before I was introduced to the Versah drill system. We use our surgical guide, and our surgical guide is made as a duplicate from the denture that's going to be converted, so we know exactly where the occlusion is. And the surgical guide that is provided me by the prosthodontist in this case allows me to have those pathways on the lingual, so I can see the position of the teeth, my emergence within the flange of the denture, and use it to make sure that I'm putting the implants in the position that would be restored, and I can also see where the incisal edge is. So we start with that. We follow the protocol, place the implants, ideally, as much as we can, and proceed to the next step. Once the surgery is completed, we suture. The prosthodontist asked me to place the multi-unit abutments, and I put the healing caps on them, and we're supposed to be ready for the conversion. But was I ready for the conversion? One mistake I did, and I'm going to go back, and I should have listened to Dr. Ulf Leckholm, who gave me the first course on osseointegration at the Brunnemark Clinic in 1986 in Sweden. He told me, don't put an implant in the midline of the mandible. In the mandibular symphysis, sometimes you end up with the midline suture not having adequate bone density. And when that's the case, you may risk losing that implant. And sure enough, this is what happened. So now, after the surgery is done, everything looks great. You have an implant in your hand, and the prosthodontist is ready to go to the next step. Yes, I replaced it with a wider diameter implant, but there is the additional stress. The patient wants to move on. Why did the implant come out? So I wished at that time that I had a system that would help me preserve the bone and densify the bone rather than cut away the bone. This is a 1-year follow-up with the wider implant, so we managed. It worked. But we've learned something from that case. So when we look at other edentulous jaw patients that are looking for implants, full mouth, and we are considering a planning, we're going to do immediate loading for those cases. Now we are looking at what are the opportunities and what has technology provided us to make our success rates a little bit higher, more predictable, and reduce the potential for problems or undesirable surprises. So we follow the same protocol. We plasti the ridge using the piezosurgical instruments, and then we start with our preparation, typically depending on the density of the bone. In this case, the patient had somewhat of a type 3 density in the mandible, so the osseodensification system would have been something ideal that we use. So we start with the pilot, and then we go to reverse mode and start the osseodensification preparation for the site. I'm going to show you a few videos of the preparation just to get a feel. Now I am doing a little bit less in and out motion because I'm pushing the bone first and then slowly backing out versus doing a pumping motion that you would do with a drill that cuts out the bone. And then the implants are ready to go in. We're using our parallel guides. We know that our last 2 implants, in order to emerge at a most posterior position for the loading torque to be idealized and have good support for the immediate temporization, we are placing them at an angle. So once the parallel implants are placed, we go to the posterior site, and then we proceed with our angular placement based on our surgical guide and our CBCT scan planning. And the case is completed on the surgical end. Once the case is complete on the surgical end, then we have Dr. Esquivel, the prosthodontist, starting to proceed with his work and convert the denture. And the case is finalized without having any surprises. So I must say that the fact that I was densifying the bone and not removing bone made me feel a lot better. Yes, it was not wise to place an implant in the midline. I should have listened to my teacher from 30 years ago at the Bryn Mawr Clinic, but that's what the prosthodontist wanted. And typically, I've learned when I accommodate sometimes restorative requests that don't make surgical sense, I end up paying the price. So just go with your information, go with your knowledge, and follow biology. What about guided surgery? I love the idea of guided surgery because it makes the surgical time so short. However, there's a lot of time in the planning, there's a lot of cost involved, versus some of the newer things that I was introduced to in the last few weeks from Versah. This patient came to us for full arch implants. Because of the size of the maxilla, we were going to end up with 5 implants instead of an all-on-4 case. In the mandible, he had a large mandible, and in the planning, we decided to place very long implants because we were concerned about the occlusion, which he had problems with before he had lost his teeth. These implants were 18 millimeters in length on the angled implants and 15 millimeters in the central area of the jaw. So here's the hardware. We do the preparation, we follow the guides, we put in the rings, and we place the implants. One thing that we need to be aware of when we are placing those implants is how much water irrigation actually reaches the depth of an 18 millimeter osteotomy site. So when I was doing this procedure, I had to stop a lot, make sure that irrigation had to come out with the drills a lot, because these are very long implants in the mandibular arch. In the maxillary arch, they were only 10 millimeter implants, or 10 to 11.5 millimeter implants. However, in the mandible, I was quite concerned. Nevertheless, the case went smoothly. We ended up having very nice restoration in the end. And this is the final hybrid restoration on the patient. Very happy patient. Occlusion was done. The restorative dentist in this case was the prosthodontist, Dr. Israel Finger, who was the former director of the prosthodontics program at LSU, and who conveniently now works in private practice in the same building where my office is. So George was very happy with his final restoration, and so was I, and so was Dr. Finger. So it's great, but there is some cost in this procedure. There is a lot of time in the planning. While the surgical procedure is quite short, it took 47 minutes from start to finish for doing both arches, and this is while being careful, but we spent days in the planning. So is there something out there that could help us? The surgical hardware is quite cumbersome. You have to put in the different guide sizes. So it also takes a little bit more time and effort than what a surgeon would do when placing implants regularly. We compared that closed ring technique to the Versah C-guide technique, and I'm looking forward to using that system. I realize it is just out and about in production in the next couple of weeks or so. But in my opinion, from what I've seen, what the information that Salah has given me, it's better access, there's better cooling, so we're not worried about overheating the bone, and there is better vision for the operator, plus it preserves the bone. So the most important thing is the bone preservation aspect of it. When I looked at other possibilities for using the Versah drill system, I started looking at cases that are coming now to most periodontal practices when general dentists who take weekend courses in places like Beverly Hills. This is an implant developed by a general dentist in the 90s in Beverly Hills. I believe it was called the Sargon implant. And there is a dentist in town that still uses that implant. That dentist rarely ever refers to me. So when I get a call from the dentist, I know it's a problem. And he's just the nicest guy. And he only refers the problem cases which have failed or are about to fail or are too difficult to deal with despite the fact that several failures has happened. It takes that particular person a while to refer to a specialist. So when I looked at this, I asked him, I don't see on the panoramic image that you sent me the implant, so what happened here? Did it fall out? He said, yeah, I removed the bridge and it just came out. So I just made him a temporary bridge, which leaves a lot to be desired as far as the design, and I told the patient to come see you. So when the patient came to see me, I did a cone beam CT scan, and I found that the ridge actually has a perforation on the palatal aspect and also on the buccal aspect. It was a through and through defect that was filled with granulation tissue. So I asked him, how long have you had that implant? He said, I had it for about 7 years, and it's just been bothering me from day one. So let's take a look at what we see when we open the flap. So this is a through perforation in the number 6 position, and we have a very thin ridge. The ridge is some areas 1 to 2 millimeters, and in others about 3 millimeters. So this is an area that we're not going to venture to place an implant in. We have to prepare the site, optimize the site, and then come back and densify the site. However, the patient said, you know what, I've had this temporary bridge forever. I'd like you to at least give me an opportunity. Maybe if you can just place one implant and then I can have something there because this temporary bridge is a problem. The patient happens to be a musician that has concerts all over the world. So imagine trying to play your instrument, and he uses a wind instrument, with this type of restoration in your mouth. So I told him, okay, well, let's try to preserve the bone that you have. So we use the Versah drill system in order to expand the ridge slowly using the protocol that Salah has mentioned to us over the last year or so. So we place the implant in the densa site area, and then we augment the area of the ridge for the future implant at the number 6 or maxillary right canine position. We do site development in that area, both on the buccal and the lingual, with veneer grafting, with a triple type membrane system where you support the buccal, support the lingual, and do a sandwich graft in between, and then cover everything over both membranes. So we're using 3 membranes, one on the buccal, one on the lingual, and one on the occlusal, and we allow some time to pass for some guided bone regeneration to happen. We bring the patient back, and now we have something to place the bone in. Notice on the left the cone beam CT scan of the original perforation, and notice the ridge where that second implant went in. So now we did not cut away the bone that took so much effort to build. We preserved that bone. We placed the implant where it's supposed to be placed, even though we had a lot of bone on the palatal. We placed it where it's supposed to come out for proper occlusion. So this is by design. And we still have a layer of bone on the facial surface, which was not cut away. It was densified into the buccal space. Other application that I've seen is I do a lot of immediate implants, and a lot of the patients I see are either maxillary or mandibular first molars, which I find either break a lot after endodontic treatment for several years. Not sure if it's the times, there's stress among patients, they're grinding their teeth, they're clenching their teeth. And I have patients that have some physical disabilities. This particular patient has had cerebral palsy most of her life, and it's very hard for her to clean her teeth. So she had a lot of decay. She's the sweetest person. She had come to me in the past, as you can see, to place previous implants, and she can barely afford her living, so I actually allow her to pay overtime whenever she can, because I really feel she is such a courageous woman who deals with her challenges in a very beautiful and graceful fashion. So when I take a look at this, most of the time in the past when I did an immediate molar extraction, I had a problem with getting my initial drill to engage the bone. So we didn't have anything like precision drills 25 years ago. When precision drills came out, we used those. When Lindemann drills came out, we used those. And when some of the Koreans introduced to us the drills that would core out the bone came out, we found that would be an easiest way to get something to engage in order to place the implant in the proper position. So I was using that, but at what cost? When you use a drill that will core out the bone, it will take a lot more bone away than you really want, and you need that bone. So I found that one of the better applications for this would be using the Versah drill system. Typically, I start with a precision drill if the interradicular furcation bone is very thin, and this goes for the trifurcation as well, because in the past, in maxillary immediate molar extractions, I would core out the trifurcation area, and if the bone core remains, I would push it and elevate the sinus floor along with the core. But it's difficult when the sinus floor is wavy, when it's not flat. So how about we don't cut away bone at all? How about we push the bone? How about we densify the bone? And you can literally see that bifurcation ridge or trifurcation ridge of bone expanding into the socket spaces, mesiodistally in the mandibular molar, and in all the trifurcation, palatally, buccally, mesiobuccal and distobuccal on maxillary molars. So I find that this is a great application. It actually makes the surgery a lot less cumbersome, and it's one of the nice things that I thought works quite well. We also end up with non-ideal ridges, and sometimes the non-ideal ridge comes with a non-ideal patient. Patient is impatient, wants things yesterday, doesn't seem to like anything, and we really want to get things to work for that patient without having more headaches. We want to go home, enjoy our days, enjoy our families, and be human beings just like our patients. So when we have cases like this, I would like to minimize as much as possible the amount of time. This particular patient had some financial problems, and she said, well, I really can afford only 2 out of 3 implants that my dentist has planned, so how about you just place 2 implants, and then in the future we can do something else. I said, sure, we can do that, but I can't place the 3rd implant anyway because the maxillary sinus is low and your ridge is thin. So there are 2 problems. We need to make your ridge wider, and we need to elevate your sinus floor, put it back where it was when you were about 20 years old, and build the bone below that area. So using the Versah technique, we were able to use the ridge expansion procedure, just like Dr. Rodrigo Nieva showed earlier, and place the implants in the positions that we wanted. And at the same time, we were able to do a maxillary sinus augmentation procedure right distal to the 2 placed implants. And you can see the sinus floor is quite low. We had about 2 to 3 millimeters to the sinus floor. So now we are optimizing the site for future densification. But when we place those implants and we expand the ridge, I've learned years ago that that thin bone is not there. It may look good. It may look like you have bone. But that thin crestal area of the bone, which peaks in an inverted V shape, disappears. So we have to do intramural penetration, have to augment. We can get our PRF, PRGF membranes, and all other grafting techniques in order to improve that ridge, because that bone will go away. Especially if it's right next to a tooth, you may lose bone on the adjacent natural tooth. So we do veneer grafts, and we cover it with membranes, and we wait. We allow time for guided bone regeneration, and this is the post-operative X-ray and one during the X-ray, the surgical procedure itself. And you can see to the X-ray on the left the amount of maxillary sinus bone augmentation that was done, and now it's ready to receive the implant. Did I drill out that bone when I placed the implant in the molar position? The answer is no. I worked so hard to create that bone. It wouldn't make sense to drill out that bone. So now we are pushing that bone, densifying the bone into the sinus, into the augmented bone already, so you even get a better result, and your restorative time is reduced quite significantly. Other people spoke about the maxillary sinus, and Dr. Nieva showed that. Salah showed that in the pre-symposium workshop. Dr. Mazer showed that, so I'm not going to go into a lot of details with that. But in this particular case, we only would have had about 1 to 2 millimeters to the floor of the sinus on those hopeless teeth. This patient has been a patient of mine for 20 years, and she had the same problem on the left side. So when her teeth were starting to feel mobile, she referred herself. She completely bypassed her general dentist, and she said, Dr. Nasr, you know what? Whatever you did on the left side, you have to do it for me on the right side. I already know. You've done my mandibular implants. You've done my upper left implants. I know it's time for you to do something, and can you do immediate implants like you did on the upper left side? And I said, in this particular case, the amount of ridge damage that has happened would be a risk. There are some super wide implants which I have ventured into using, and when I pushed the envelope, I paid the price. You engage bone mesiodistally, you engage bone palatally, you engage even bone buccally, and the implant has a 65 ISQ Ostel reading, and you're talking to about 55 or 60 newtons, and then you come back and you see a fistula on the buccal surface. Why is that? Because that outer layer of bone is very thin, and it just disappears with those super wide implants. As much as I love them because they anchor, you have to measure the thickness of that buccal plate of bone before you use a super wide implant, because sometime down the road, you're going to pay the price. And the price means free surgery. So obviously, we'd love to help our patients, but we don't want to spend our time doing free surgery, so we want things to work from day one. So in this particular case, we did site development with guided bone regeneration and came back with the Densa drill system to push that bone even further up, as you see on the X-ray on the right side. And the patient was pleased with the outcome. Sometimes I like to push the envelope to see how far I can go with the system, and since I haven't been using the Versah drill system for more than about 13 or 14 months. This case came by, and I told the patient, you know, your ridge is really thin. I have a technique that I will try, and if it doesn't work, don't pay me until it works. So if it doesn't work, you have nothing to lose. So I looked at this ridge, and this is a 1.5 millimeter ridge. 1.5 millimeter ridge is really pushing the envelope too much, but I said, let's see how far we can go with this. So we use our piezo microsaw, and I like that particular size. You have to be very careful with that particular size because it's super thin, and you have to keep your hand in motion all the time, irrigating all the time. You don't want to overheat the bone, and you don't want to break that tip because some of those tips are about $300 or $400 each. I must say, knock on wood, since I've started piezo surgery a few years ago, I have not broken one tip. But since I just mentioned that, I'll probably break a tip on Monday. So this is my first go-to microsaw that I use. I like that it has millimeter markings, so I know how deep I'm going. And you are prepping the site to depth. We're prepping the site to depth. We don't want to try to push deeper. We want to have that trough so we are able to place our Densa burr system without trying to drill any further deeper. Granted, as the deeper you go, the thicker the bone is, but sometimes you have those hourglass type ridges, and you may get a fenestration while you're doing that. So it's best to just go to depth and then start using the ridge expansion with the Osseodensification system. So in comes the Densa burrs, and I couldn't even get my pilot Versah drill to engage because the slot was too thin, and I was afraid to damage the bone. So I used a precision drill, which is the pyramidal shaped drill that comes with some implant systems to create an access for my pilot drill. So I used a precision drill prior to the pilot drill, and then I created the access for counter clockwise motion with the Densa burrs. If we look at the slide on the right side, you know that that bone is gone. Whatever is there, this is just nothing but a resorbable membrane that will resorb. So we have to plan on augmenting that area. Once that is expanded, you can see sometimes you get microfractures. Anybody who has done ridge expansion or ridge split has seen this happen, and I'm sure all of us have learned the hard way on some of those cases. However, we were able to engage the implant, and it did torque at 45 newtons with about 60 on the Ostel system. Place the implant, oversize the Densa site preparation and the Osseodensification, and allow it to rebound back. Don't force that implant in because it's just simply going to necrose that thin bone. And then we do our guided bone regeneration in order to augment the ridge, and we allow time for the implant to integrate, and we can see the bone picture has survived the surgical procedure quite nicely. This is Caleb. So I'm going to switch gears a little bit because I know everything that could be used with the Versah system has been used. So I'd like to share with you this case. I'm not sure if it has been, if the Versah system has been used in similar cases. However, I find it's a great application. Caleb lives in Dallas. Caleb's father and mother used to live in New Orleans. They got divorced, and his mother moved to Dallas. Because everybody who knows his father lives in New Orleans, including his dentist and his doctor, when Caleb comes to visit his father, he sees his father's dentists, he sees his father's general family doctor, and the mother just puts him on a flight. Southwest Airlines has a flight that takes from Dallas about an hour and 40 minutes, and he's in. So he comes on the weekend or once a month to visit his father. So Caleb got referred to me from a very good friend of mine, Dr. Mark Bellello, who happens to be with me in the SPEAR VIP Specialist Club and in the restorative side of that. And he told me, you know what, I want to do something with Caleb because this is what Caleb looks like. Caleb is 11 years old. Caleb is missing several permanent teeth, but the one that bothers him most, now that he's 11, kids in his class are starting to tease him about the way this tooth looked. And he's just the sweetest kid. we wanted to do something for this kid. So I looked at it, and I called Mark, and I told him, you know what, he's 11. According to all the studies on facial growth, we have to wait at least 8 to 10 years before I place implants in this maxilla, because we don't want to end up with an implant that gets ankylosed in an apical position and have an aesthetic problem on a kid who's 11 years old for the next 70 years of his life. So I can take it out, and I can augment the ridge, and we hope that that bone won't resorb by the time he's 20 or 21, so we can have something to place implants in if we're still around. But let's think of what else could be done. So we took a look at this, and I spoke to the orthodontist. Brad Gottsagen is the orthodontist in my group, and he's just an outstanding guy. I told him, you know what? I was lecturing at the European Academy of Aesthetic Dentistry in Norway in 1999, and the keynote speakers at the end of the meeting came and gave a presentation just before the gala dinner. I told them those wonderful gentlemen who looked like they were in their late 70s, who have been friends for the past 50 years, who were professors at the University of Oslo. And they showed us cases that I had never seen before. When I looked at Caleb, I thought maybe I can do something like those two Norwegian professors. He has that supernumerary tooth, which is actually two pieces. There is a coronal looking part, and there is an odontome apical to that that's encroaching on the adjacent tooth. And this is when Caleb came to me prior to the procedure. So I looked at the literature, and I found that those two particular professors have published a 40-year follow-up on autotransplantation of premolars in congenitally missing maxillary incisors. 40 years. Christensen published after that. The group with Plackwitz verified their results by doing cases, and Lundgren as well. So there's a lot of evidence in the orthodontic literature that supports this approach. And this is one of the cases that was done by the Plackwitz group that was published in 2013. And basically, you place a premolar in the missing maxillary central incisor position and allow it to orthodontically erupt. As long as that tooth is not, the root is not completely formed, it has to be done in a gentle manner with autotransplantation. And now we can give an 11-year-old kid a tooth today rather than 10 years from today, allow it to erupt orthodontically along with his natural braces that we'll have at that teenage year anyway. So here is my cross-section. We're doing some measurements to see my donor site, my recipient site. When Caleb first came to me, his maxillary right molar, primary molar was still there, and this was in the summer. By the time he came to me in the beginning of the winter, the tooth had come out, which means that premolar is erupting. So I decided to transplant the maxillary right premolar rather than a mandibular premolar or maxillary left because of the anatomy of where those other teeth were and the complications with possible surgical extraction of that tooth, making sure that I want to keep that intact follicle to preserve her to epithelial root sheath so the tooth would grow naturally. So we're going back to our biology on this. So here's the donor site, here's the recipient site. Surprisingly, there was a good bone, reasonably good bone thickness. There was a little bit of loss of bone height because of the position of the supernumerary teeth, the odontoma and the tooth itself. So I knew I needed to expand the ridge a little bit to get that premolar to fit. It has to be snug, firm, but you can't force it. So it takes a little bit of trial and error with testing the tooth in position. One thing also I've learned over the years is when you place an implant in a congenitally missing tooth, about 75% of the time, the moment you pass the cortical plate, you're going to drop into a huge marrow space. There is nothing there. It's complete atrophy of the trabecular bone, and it's a hollow area, just like what you see when you remove a cyst. and there's just a large gap. It's almost like you dropped into a sinus. And I've lost a couple of implants like that about 10, 12 years ago, and I learned my lesson. So I've now, in those cases, been grafting the bone first and then coming back and putting the implant. But in this particular case, why not densify the bone? And this way we're not cutting away the bone. So as careful extraction as possible has to be implemented in those particular cases. So we remove the supernumerary teeth, the coronal part, and the odontome that had a hook on it, which, as small as it is, it was surprisingly somewhat difficult to remove if you don't want to damage the bone. Of course, it's easy to remove if you're okay cutting away bone, and this defeats the purpose. We're not trying to cut away anything here. And we go through our series because I'm now expanding and I am densifying at the same time, so I'm using the Versah drills to achieve that. And once I felt this looks reasonable, I decided to remove the tooth as atraumatically as possible while not touching the root surface. You cannot touch the root surface because that will damage the epithelial root sheath and reduce your chance of success for that tooth to grow normally compared to the adjacent natural teeth. So we take that tooth out and we test it. We test it in the recipient site. Most of the literature says take it back and put it into saline. But I prefer to take it back and put it into the socket where it came from. Saline would preserve it, the socket will keep it alive with blood supply. And I'll have more time to work because I know there is blood supply. So this is a much better approach than putting it in a gauze with saline or in a petri dish with saline or a dappen dish with saline. So I put it back in the socket and I go back and I realized that my site optimization was a little bit too far facial. And when I come to place this premolar, it will be a little bit too far facial and it wouldn't fit in. So I had to go back to my pilot and move in lingual or palatal and start again with another sequence and expand into the already expanded space. So I have now a double expansion towards the palatal and towards the facial. So after the densification is done, I take my probe and measure, is this the dimension I have? I'm now looking at the premolar, I can measure the premolar, and I now can transfer it into the recipient socket. And the tooth gets transferred, careful not to touch the follicle of the tooth, and it's placed in the position just like any impacted maxillary canine or premolar. Typically, they are in a position that needs to be orthodontically guided into the appropriate spot. And we gently closed around it. We made sure that it's stable. You don't put brackets on it right now. You don't want to traumatize it. You don't want to touch it for about 8 to 12 weeks. If you've done a good job, it will stay there. And we suture around it and put Caleb on a plane back to his mom in Dallas. Since I haven't had the chance to see Caleb for a few weeks after that, I told him, let me take a CT scan so we can compare things when you come back to visit New Orleans and your father during the holidays. So we took a CT scan to make sure that we have everything in position and the tooth is there. I had my front desk call his mom every couple of weeks or so, make sure that that tooth is not being loaded or traumatized and make sure that it's functioning well. And said he's very happy. He's just besides himself that he has a permanent natural tooth. And he just looks like some of the other kids who are having braces in his class now. So in this particular case, we've done bone preservation to optimize the outcome. So it's an outcome optimization on a clinical case that I thought would be a nice application. I haven't seen it with the Versah drill system before, so I thought this would be a nice case to show you and see that the bone has been preserved on the facial aspect of that tooth in both cross sections, and now orthodontic treatments will begin. This is the before and after of Caleb. This is the supernumerary tooth, and now this is the premolar, which will be guided so that once everything is in place, his restorative dentist will shape it to look like a central incisor, just like all the articles that were published from Norway over the last 40 years. And then he's coming back to town for the orthodontist to work on that tooth. His appointment is actually scheduled on the last Saturday of the month, and he's coming to my office on a Saturday. I don't work on Saturdays. I'm going there especially for him, and then going with him to the orthodontist to make sure everything is heading in the right direction. This picture, he took it himself. He used his iPhone and sent me a picture. I told him, Caleb, I'd really like to see how you're looking. So he took a picture and sent it to me. And it really felt great that this kid was smiling for the first time. Versah has changed my thinking in implant dentistry. And even though this is a misquote by Victor Hugo, I like it, so I decided to add it. There is nothing more powerful than an idea whose time has come. And I think this is an idea whose time has come. Thank you very much.